Welcome to the deep dive. Today we're diving into a really pivotal shift in how we treat a common and serious problem.
Yeah.
Blocked arteries, down in the lower abdomen and legs.
Yeah, for a long time, the main answer was often major surgery. It's amazing how quickly things changed.
It really is. We're looking at a time of just incredible progress.
Absolutely. And right at the heart of that transformation is, well, one single, really impactful piece of research.
Exactly. So our mission today is to unpack this landmark 1990 paper. It was published in Radiology by Paul Maas and his team.
Ah, the Paul Maas stent paper.
That's the one. The title's a bit of a mouthful. Placement of balloon-expandable intraluminal stents in iliac arteries. First 171 procedures.
Right. Sounds dense maybe, but its impact was just enormous.
Totally. This study, it basically paved the way, reduced the need for that major surgery dramatically over the next decade or so.
It truly did, because before this, if you had significant blockages in your iliac arteries, those big vessels feeding your legs, the main endovascular option, the minimally invasive one, was really just balloon angioplasty.
Right, where they thread a balloon in and inflate it, try to squash the blockage flat.
Exactly, squashing the plaque against the wall.
Okay, and, well, angioplasty, it had its place,
Mm-hmm.
but it wasn't like a perfect solution, was it?
No, definitely not. And this research on stents, it offered the promise of something potentially more durable, a less invasive way to actually prop those arteries open.
So this deep dive, we're really exploring how this specific study laid the groundwork, essentially rewriting the medical playbook for this condition.
So let's maybe set the scene a bit more. What was the actual problem Dr. Paul Maas and his team were trying to, well, solve?
Okay, yeah, good point. We're talking about aortoiliac occlusive disease. So think of the aorta as the main water pipe coming into your house, right?
Mm.
And it splits into the iliac arteries to send blood down to your legs. If those pipes get clogged or narrowed, well, that causes big problems,
Big Crumbs is right. Patients might get claudication.
which is that pain or cramping in the legs when you walk.
Exactly, because the muscles just aren't getting enough blood, enough oxygen. Or, in the really severe cases, it could lead to limb-threatening ischemia.
Where the blood flow is so bad, the leg is actually at risk.
Yeah, I mean, risk of tissue death, even amputation. A very serious situation.
And like you said, before stents really became a thing, the main non-surgical tool was balloon angioplasty. Inflate the balloon, push the plaque aside.
But it had its downsides, as we sort of hinted at.
Like what specifically?
Well, angioplasty alone, it could cause complications. Things like dissection.
A tear in the artery wall itself?
Precisely. Or elastic recoil, you inflate the balloon, take it out, and the artery just kind of springs back, narrows down again.
Ah, okay, so the effect doesn't last.
Right. And then there was restenosis. That's the artery re-narrowing over time, which was unfortunately pretty common.
Okay, so against that background, with the limitations of angioplasty, this 1990 Paul Maas study comes along.
Yes, offering a potential solution. And it was a multi-center trial, which is important, done at several hospitals.
Right, strengthening the findings. And I looked at, 171 procedures?
In 154 patients. And crucially, this group included people with both that severe limb-threatening ischemia and those with the less severe claudication.
So a real mix of severity.
A real mix. And the core question they were asking was, fundamentally, can these new balloon-expandable stents, these tiny metal mesh tubes, can they safely and effectively prop open these iliac blockages?
It's a big step beyond just pushing the plaque aside, isn't it?
Yeah.
It's about creating a scaffold.
Exactly. Providing structural support.
And how do they study it? What was the method?
Well, it was designed as a retrospective review, but of prospectively collected data. So they'd been systematically gathering the information as they did the procedure.
Ah, okay. So they knew they wanted to analyze this later.
Seems likely, yeah. They then went back and analyzed those outcomes.
And the patients, what were they like?
The average age was around 62, mostly men. And like we said, a significant chunk, 48 patients, had that really critical limb-threatening ischemia.
Wow, nearly a third.
Yeah. And the other 106 had the intermittent claudication, so it really shows they were tackling serious disease here.
Okay, so who actually got a stent in this study? Were there specific rules for deciding?
Yes, the criteria were pretty specific. Often it was used after an initial angioplasty attempt hadn't worked well enough.
What defined not well enough?
Good question. So if the angioplasty caused a dissection, a tear, or if more than 30% of the narrowing was still there after the balloon, or if there was still a significant pressure difference, more than 5 millimeters of mercury across the treated area, those were triggers to put in a stent.
Right.
They also included patients who had restenosis, re-narrowing after a previous angioplasty, and also patients who had complete 100% blockages to begin with.
Right. And presumably there were reasons not to use a stent, too, exclusions.
Oh, absolutely. They were careful. They outlined exclusion criteria and also relative contraindications. Things like contrast dye leaking out of the artery after angioplasty, suggesting a perforation, or if the iliac arteries were really twisted and tortuous.
Making it hard to get the stent delivery system up there.
Exactly. Also, very heavy dense calcium in the artery wall could be a problem, potentially stopping the stent from expanding properly.
Okay, that makes sense.
Other things they considered were aneurysms, bulges in the artery, severe high blood pressure, patients who couldn't feel pain well in their leg, which could mask a complication.
Right.
Also significant narrowing further down in the femoral artery, or just generally poor outflow, meaning poor blood flow in the vessels below the treatment area.
So they were really selecting patients carefully.
Very carefully, focusing on where they thought it would work best and be safest, based on what they knew then.
Okay, so let's talk about the actual device, the stent itself. What was it like? How did they put it in?
So the stent they used was made of stainless steel. It was this expandable metal mesh tube, unexpanded, maybe the size of a short matchstick, tiny. And it was crimped or folded tightly onto an 8mm angioplasty balloon catheter.
So the stent is mounted on the balloon.
Correct. The whole setup was then delivered through what's called a 10 French sheath. Basically, a small introducer tube placed into the artery, usually via the groin, minimally invasive access.
And as you said, often this wasn't the very first thing they did, right? Angioplasty often came first.
That's a really key point. In many cases, stenting was kind of the backup plan, almost a rescue maneuver in this early phase.
So they try the balloon.
They try the balloon, and if it met those failure criteria we talked about, dissection, too much leftover narrowing, that pressure difference.
Then they deploy the stent.
Then they'd inflate the balloon with the stent on it, expanding the stent to push against the artery wall and hold it open.
Got it. What about medications? Did patients need special drugs?
Yep, there's a protocol. Patients got aspirin and epiridamol. Both are anti-platelet drugs, make the blood less sticky. They started those a couple of days before the procedure and continued for 3 months after. Plus, they got heparin, another blood thinner, actually during the procedure itself to prevent clots forming right then and there.
Okay, standard stuff now, but important they establish that routine. So the stage is set. They know who gets a stent, they have the device. Where exactly were they putting them? In the iliacs, obviously, but where?
Right. So the majority, 181 stents, went into the common iliac artery. That's the bigger segment, closer to the aorta.
Right.
Another 80 went into the external iliac artery, which is the branch heading down towards the thigh. And interestingly, 17 patients actually got stents on both sides, in both iliac arteries. And 21 patients got stents in both the common and external iliac on the same side.
So treating multiple levels of disease sometimes.
Exactly. And in a few complex cases, 12 patients, they combined the stenting with some kind of open surgical procedure further down the leg to improve the outflow.
Okay, hybrid approach even back then. All right, so 171 procedures done. What did they find? What were the big results?
Well, the results were, frankly, quite remarkable. One of the most immediate striking findings was the huge improvement in the pressure gradient across the treated artery.
The pressure difference we talked about.
Yeah. Before treatment, the average gradient was 36.4 millimeters of mercury. High pressure drop, meaning a bad blockage.
Right.
After stenting, it dropped to just 1.6 millimeters of mercury on average.
Wow. That's almost nothing. Like removing the blockage entirely.
Pretty much. It shows how effectively the stent eliminated that obstruction and restored near-normal flow dynamics. Very few arteries had any significant gradient left afterwards.
Okay, that's a very clear technical success marker. But what about the flip side? Complications. Any downsides emerge?
Yeah, like any procedure, there were complications. The overall rate reported was about 9.7%.
Okay, what kind of things?
Well, notably, 2 patients had early stent thrombosis. The stent clotted off within a week.
Oh, that good.
No. But importantly, both were successfully treated using more percutaneous techniques, basically going back in with catheters to reopen the stent.
Okay. Salvageable. What else?
6 patients developed groin hematomas, bleeding or bruising at the access site. Some needed transfusions or even surgical drainage.
Okay.
There were 4 cases of distal embolization where little bits of clot or plaque break off and travel downstream.
Blocking smaller vessels.
Right. And those required surgery and embolectomy to remove them. One patient had temporary kidney problems, which resolved, and a few other isolated things. dye leaking out, a pseudoaneurysm, a minor dissection.
So just under 10% complication rate. Seems reasonable maybe for a new procedure treating serious disease.
For the time and considering the potential benefits, yes. And that leads to the next question. How did the patients actually do clinically? Did their symptoms get better?
Right. The bottom line for the patient.
This is where it gets really compelling. At the first follow-up, just 2 weeks later, a huge majority, 114 out of the 154 patients were asymptomatic. No more leg pain.
That's a massive improvement, quickly.
Huge. And by the latest follow-up, which averaged about 6 months, 113 were still asymptomatic. The numbers with a moderate or severe claudication dropped way down. Some patients who had non-healing wounds or pain even at rest, they showed improvement too.
That's fantastic.
Yeah.
Any negative outcomes in follow-up?
Unfortunately, yes. One patient did end up needing an amputation during that follow-up period. But overall, the researchers concluded there was a clear net clinical benefit in 134 out of the 154 patients.
So the vast majority really benefited clinically. Did they measure blood flow improvements too?
Objectively.
They did. They looked at the ankle arm index, or ADI. That's a ratio of blood pressure in the ankle versus the arm. Lower ratio means worse flow.
Right.
And they showed clear improvements in the ABI after stenting. And importantly, those improvements held up at the 6-month follow-up.
Good. Sustained improvement. And the stents themselves, did they stay open?
Well, in the group that had repeat angiograms, the X-ray pictures, the patency rate, meaning the stents were open, was 100%.
Perfect. In that subgroup. In that subgroup, yes. And for the others, based on their clinical status and those ABI measurements, the researchers inferred that the stents were likely open as well. Also, critically, they saw no signs of the stents moving or migrating and no aneurysm formation near the stents during follow-up.
Okay, so really positive early results. But as with any study, especially an early one, there were limitations, right? The authors mentioned some.
Yes, absolutely. And it's important we acknowledge those. It was a retrospective review looking back at data. It wasn't a randomized controlled trial.
The gold standard.
The gold standard, yeah, where you'd randomly assign patients to get either a stent or just angioplasty, for example. So even though they had criteria for stenting, you can't completely rule out selection bias.
Okay.
And also, the follow-up was, relatively limited at the time they published, average 6 months up to 24 months. Valuable, but not super long-term data yet.
But you have to frame that.
Yeah.
This was one of the very first big reports, right?
Exactly. For this specific technology in this location, it was pioneering work. Groundbreaking stuff.
So, bearing those limitations in mind, what was the big picture impact? Why do we call this a landmark paper?
Because it provided the first really solid body of evidence that these balloon-expandable stents could be used safely and effectively for iliac artery blockages. It fundamentally challenged the status quo.
Where endovascular treatment was basically just angioplasty.
Which, as we discussed, had those significant issues: recoil, dissection, restenosis. This paper showed there was potentially a better endovascular way.
And it sounds like stents could maybe handle tougher cases than angioplasty alone?
That was a key part of it. Stents offered that mechanical scaffold, that support, so you could potentially treat longer blockages, more complex disease, maybe lesions that just wouldn't respond well to a balloon alone.
Right.
Suddenly, the really big open surgeries like an aortobifemoral bypass, a major operation.
Yeah, huge surgery.
Huge surgery, long recovery, or an aortic endarterectomy. These now had a serious, less invasive rival showing really promising early and midterm results.
And this study must have just kickstarted more research and development.
Oh, absolutely. It lit a fire. After this, stent technology just exploded. We got lower profile stents, easier to deliver through smaller access sites.
And get safer.
Safer, yeah. And remember, this first stent was bare metal. Later came drug-eluting stents, coated with medication to help prevent that re-narrowing, that restenosis issue.
Addressing a key limitation.
Exactly. And alongside that, you had better guide wires, better catheters, much better imaging, all building on this foundation, allowing us to treat more and more complex blockages without resorting to open surgery.
So looking back now, have later studies, maybe comparing stenting directly to surgery, have they backed up these early positive findings?
By and large, yes. Numerous trials over the decades have really confirmed that for most aortoiliac disease, endovascular treatment with stents is safe, effective, and often achieves results comparable to open surgery.
But with major advantages for the patient.
Huge advantages. Less invasive, shorter hospital stay, much faster recovery. For many patients, it became the preferred approach. Some big trials showed pretty similar long-term patency, similar rates of keeping the vessel open between stents and surgery for specific types of iliac disease.
And the technology keeps evolving even now, right? You hear about covered stents,
Yeah.
hybrid procedure.
Exactly. Covered stents with a fabric graft covering came along. They seem helpful in certain situations, maybe really complex blockages or if there's a risk of rupture.
Okay.
And yeah, hybrid procedures are more common now too, combining some minimally invasive stenting with maybe a smaller open surgical part, often in the groin, to tackle really extensive disease effectively.
So it feels like if you trace it all back, this 1990 paper was really the starting gun for a whole new era.
I think that's fair to say. It absolutely laid the foundation for this massive shift. Today, for the vast majority of people needing treatment for aortoiliac blockages, an endovascular approach, usually involving stents, is the standard of care, first-line treatment.
Which is interesting because that's maybe different from blockages further down the leg, below the groin.
It is, yeah. It's quite a contrast. Treating disease in the arteries below the knee, for example, endovascularly, has proven much more challenging long-term. But the iliacs, they turned out to be a really successful area for stenting, and a lot of that success traces back to this pioneering work by Paul Maas and his colleagues.
So just to wrap it up then, this single paper, Paul Maas et al., 1990 in Radiology, a major, major turning point.
Absolutely. It provided that crucial early evidence. Balloon-expandable stents were safe, they were effective for iliac arteries. It truly revolutionized treatment.
Reducing the need for big operations for countless people.
Precisely. Offering patients a much less invasive option with, really good results in terms of symptom relief and restoring blood flow.
It really makes you think, doesn't it? How just one new technology, when it's studied properly and the results are shared, how it can completely reshape how doctors practice medicine.
And improve so many lives.
Yeah. It kind of prompts you to reflect maybe on the innovations happening right now in all sorts of fields. What things are being explored today that might, 10, 20 years down the line lead to similarly dramatic shifts? What current challenges might be completely transformed by something new that's just emerging? Food for thought.